I'm very honored to have Dr. Carol Manning with us here today. Dr. Manning is the director of the Memory Disorders Clinic, co-director of the Virginia Alzheimer's Disease Center, Harrison Distinguished Teaching Professor of Neurology, director of Neurobehavioral Assessment Laboratory, and Associate Chair for Faculty Development in the Department of Neurology at the University of Virginia. Dr. Manning is a board-certified neuropsychologist. Good morning, Carol. Welcome.
Good morning. Thank you.
Appreciate you being here. So if you would you tell us a little bit about your work and what the Memory Disorders Clinic at UVA does?
Yes, I'd be happy to. So the Memory Disorders Clinic at UVA serves people with cognitive impairment, dementia, neurodegenerative disease, in particular, people with Alzheimer's disease, vascular dementia, other kinds of dementia. And when I say we we treat the person with dementia, him or herself, as well as consider the support system, which typically is a primary caregiver. So we consider the entire system as opposed to just the individual. We are a multidisciplinary clinic, and so that means that patients and family members have access to neurology, neuropsychology, nurse practitioner, social work. We have care managers, we have nurse coordinator, we have physical therapy, occupational therapy, speech and language pathologist. We have a whole crew to help provide care for people who are living with dementia.
Wow, yeah, that's impressive. That's very comprehensive. So you mentioned Alzheimer's and other forms of dementia. Would you talk a little bit about that? What those different forms are. Obviously, you could spend an hour talking about that, but briefly, different forms of dementia and how you recognize, how you distinguish those.
Sure. So the most common form of dementia is Alzheimer's disease. Then the following Alzheimer's disease is vascular dementia, and vascular dementia in and of itself is a risk factor for Alzheimer's disease. So when one of the important things that we do is make a diagnosis. And so when someone has vascular dementia, there's increased risk for Alzheimer's, but also there's a diagnosis called mixed dementia, which means more than one kind of dementia, typically means a combination of vascular and Alzheimer's dementia. Other common kinds of dementia include dementia with Lewy bodies, or a primary progressive aphasia, which involves more language disturbance early on. One of the first things we do in the clinic is get the diagnosis, because that is important in terms of understanding what the prognosis is going to be, how things are going to progress down the road, and gives us information on not just what we might expect, but gives us some information on the timeline and how we can help the person and their family. So the diagnostic process in the clinic involves an appointment with a neurologist, neuropsychological testing, neuroimaging, and sometimes other biomarkers that can be helpful in determining what the type of dementia is.
Understood. So do you typically see folks say they've seen their primary physician and then they're referred to you? Is that normally how it happens?
Typically, that is how it happens, that we get the referral from the primary care physician. That said, because we specialize in dementia, we get referrals from all kinds of providers, including neurologists, who have questions about what the type of dementia is. And so in terms of the diagnosis, and also because once the diagnosis is made, people can be seen in our multidisciplinary care clinic. And so they can receive services specifically for people with dementia that other places might not have, or people might not have access to. And one of the things I didn't mention is that we have a significant amount of research going on. And that research involves everything from clinical trials or medications that we consider have promise, to our care coordination program is actually a research program that enables people to have access to care managers, but also as part of our research protocol so that we can show the efficacy. Hopefully, we believe it is efficacious, of people receiving care coordination that they wouldn't otherwise have. I also want to say that we have something called the Virginia Alzheimer's Disease Center Registry, and we encourage our patients who are interested to sign up for the VADC registry. And what that does is enables us to contact them if we think there is research that they might be interested in. It can be anything from a clinical trial to a behavioral treatment to something for caregivers, or the persons with dementia themselves. And by signing up for the registry, people can always say no, they're not interested when we contact them and say, here's something, are you interested? But it does enable us to say, are you interested, and to contact them and reach out to them.
Gotcha. So Carol, if I have a spouse or a loved one where I'm concerned about cognitive issues, what behaviors should I be looking for? What would be concerns?
So there are memory changes that occur with normal aging, and the normal changes tend to be things like forgetting names or forgetting where we put our keys, but forgetting entire events, or an example is, if you walk out into a parking lot and you forgot where you put your car, that's normal. But if you forget what your car looks like, or forgot how you got to wherever you are, that would be more concerning. We look for changes in ability to do things that the person knew very well. So someone who has cooked dinner for years and has made the same recipes and suddenly can't remember how to make them, or can't get things on the table. Or someone who is making mistakes, significant mistakes paying bills, not just forgetting to pay a bill once in a while, but paying them twice or three times, or making significant mistakes that can have financial impact. There can also be changes in personality, and that would be something that is worrisome as well.
And when you say changes in personality, what do you mean by that? Aggressive behavior?
So it could be someone who becomes more aggressive, or significantly more irritable, someone who becomes very apathetic and doesn't have the initiative to get up and do just the normal activities of life, representing a significant change from what they were previously.
Gotcha. Could you talk a little bit about the different stages, early, mid, late stage dementia?
Yeah, so early stage dementia is more ability to perform our regular activities of daily living. Activities of daily living include things like bathing, brushing teeth, toileting, dressing, those sorts of things. And in early stage dementia, people really don't have problems with that, but they might have difficulties with what are called instrumental activities of daily living, and that's more the balancing the checkbook, or managing small amounts of money, making a tip at a restaurant. When we start to see, so early on, there would be those changes. And we typically, with Alzheimer's disease, but depending on the time of dementia, sorry about that, we'll see changes in behavior, or I'm sorry, I lost my train of thought. My phone just rang there
Okay.
unexpectedly. So we were talking about early stage dementia, where you might see personality changes, you might see changes in the more difficult activities of daily living, but you also see memory change. So forgetting recent events more than we might anticipate. Um, so it's not just forgetting someone's name, it's forgetting an event, forgetting something that happened. In middle stages, people start to lose their activities of daily living. They have more trouble dressing, certainly dressing appropriately. They might forget to bathe or think that they've bathed when they haven't. In later stages of the disease, the activities of daily living are basic activities really are become much more difficult. People might have more problems with language and actually speaking. They might be much more irritable. They would be more likely to have what's called sundowning, which is in the early evening. They get more agitated. People in later stages start to wander. And then in very late stages of the disease, things start to shut down and they really are doing very little in their daily lives, and maybe just confined to their beds.
Gotcha. So, in terms of daily interactions with, with the person with dementia, what are some important things to know about how the family communicates, interacts with that person?
I think it is important to remember that correcting them and insisting that you correct them on what day of the week it is or what actually happened is becomes less and less important. And being with the person where they are reacting to the emotion as opposed to the actual content of what they're saying is what becomes important. And that's a shift. Many years ago, people thought it was extremely important to orient them to exactly what's happening. That doesn't matter. They're not going to remember. Um, Respond to the emotion of the person and try to join with them, and provide help in ways that feels comfortable to that person. If the person becomes fixated on one thing, try to shift their attention. Just try to bring up something else rather than to force them to do something. Just change the subject and try to shift the atmosphere a little bit.
Gotcha. Um, so I know one of your clinical interests, mentioned in your bio, talks about the well-being of the caregiver, and that, that's certainly something that I see in my practice is the strain that the dementia puts on the primary caregiver. So what are some of the ways that we can do that we can take care of the caregiver?
Okay, so that is something I care deeply about, and that's something we focus a lot on in this clinic. Our healthcare system is extremely reliant on unpaid family caregivers. Typically, there is one primary caregiver, and very often that primary caregiver is the spouse, who is the same age or older as the person who has dementia. We know that family caregivers experience significant stress, increased depression, um, caregiver burden, and overall they experience poorer health than people of the same age who are not caregivers. We also know that these factors contribute to caregivers being unable to provide care, and that caregivers have increased mortality. So if something happens to that primary caregiver, there is a significant lack of care for the person with dementia, but also it's terribly stressful for the primary caregiver. So recognizing the what the burden is in the primary caregiver. Often primary caregivers tell me, oh, I'm just fine. But when we go through item by item what's going on, they are able to recognize, yes, they're under a significant amount of stress. And that's a place where family members can step in and can help out. And they don't even have to be here. They can live in other parts of the country. And just like we are doing this virtually right now, family members can help virtually. They can get on the phone and help make make appointments. They can look into things like insurance or whatever it is that can be done virtually, and even just talking on the phone to the primary caregiver to give emotional support. We have a lot of initiatives in terms of our own research that are aimed at helping the primary caregiver get support. So we have a program called Effective Strategies Program for Caregivers, which is a study which is running right now, which is providing primary caregivers with education and emotional support so they have better tools to deal with this. Our Care Manager program is really aimed towards helping the caregivers get access to resources, education, and emotional support.
That's great. Yeah. I can't tell you how many times I hear in my office, if it's the husband, the wife says, no, no, I'm fine. And then one of the children will be there and pipe up and say, but mum, you've been taken to the hospital twice by ambulance in the last, since the last time we saw you. Caregivers somehow feel like it's a failure if they don't take care of the spouse, if they don't do everything themselves.
That's exactly right. And so I really try to be very clear that they will not be able to take care of the person with dementia if they themselves are ill. And so taking care of themselves is paramount.
Right, absolutely. Yeah. Carol, would you talk a little bit about treatment options? I know there are um some new drugs that are out that treat early stage Alzheimer's, early stage dementia, as well as other non-drug treatments.
So I wish I could tell you that there was something that was really going to change the course of the disease and really going to help those with dementia right now in terms of medication. There are some new medications that have been given FDA approval. While the newest one, there is some benefit, it isn't clear how clinically significant that is. That is a medication that does not have is not paid for by Medicare at this point in time. Medicare is reviewing it. And aducanumab, which is the one that was just prior to that, we, along with other major medical centers, have decided not to offer it. Aducanumab is the new one that I was talking about. And people are already asking about it. And the current cost of that is about $26,000 a year, and Medicare has not decided whether or not they're going to pay for it. And again, the data show that it helps. There is statistically significant improvement, but whether or not we see a clinical improvement, that is whether someone will notice a benefit themselves, is really yet to be seen. We have medications that slow the rate of decline for about 3 years, and we use those and prescribe those. They're not a magic panacea. One of some of the best treatments we have at this point are actually behavioral interventions, and people would much prefer if there were a drug they could take. Unfortunately, that there isn't a magic drug, and behavioral treatments can be very effective. And that's one of the things we work with people on, is to think about the individual and what the behaviors are and how we can work around them. That specifically involves the caregiver typically. And also there are things that are important for all of us. These are things that are important in middle age to help prevent the onset of dementia. And once someone has dementia, they're important lifestyle factors. And what we know those to be are Mediterranean heart healthy diet, so whole grains, fruits, nuts, exercise, cardiac aerobic exercise is very important. Cognitive activity, doesn't matter what kind. People say, do I have to do crossword puzzles? Well, do crossword puzzles if you enjoy them. But it can be any kind of cognitive activity. Social interaction is also really important as well. So those lifestyle factors are really important.
Absolutely. So what else do you tell folks at the clinic? Do you discuss working, with other professionals, and if so, whom?
I'm not really sure. They should continue
In
to see
in
their
terms
primary
of
care doctors, and
right.
um, I'm not sure what else you'd be referring to.
So, legal professionals, geriatric
Absolutely.
care
One of the things
managers.
we stress, and that is early on, that's so important in the diagnostic process, and it's early. That's why it's important to get diagnosis early. Is we really want people to, the earlier on someone gets a diagnosis, the more they can participate in their own care and decisions about that. That's critically important. We want people to have wills. We want people to have advanced directives. We want them to talk about exactly, in terms of advanced directives, what it is that they want specifically. So it is to have, it's really important to have power of attorney in place. And so when the person is still able to make decisions about who they want to have medical power of attorney, and other power of attorney otherwise.
Gotcha. Do you have situations that come up where, let's say the spouse or loved one contacts you, but the person is refusing treatment, doesn't want to see a doctor, etc. What are some of the ways that you might address that?
Well, we cannot force a person to come in, but one of the things we have often found is that family members often think that people are going to have a harder time with that people with dementia are going to have a harder time with the diagnosis than they do. And when family members say to us, "Don't mention the word dementia. Don't tell the person that they have Alzheimer's disease," we have often found that that is detrimental to the person with dementia, and that that is not treating them with the respect that they are due. So we strongly recommend against family members not telling the person with dementia that they have dementia. And if someone won't come in, we talk through the situation with the caregiver about what is going on, and work with them individually to see, okay, have you tried this? Have you tried this, in terms of getting the person to come in? And once people come in, I like to think that we are a nice and friendly environment, and the person with dementia, typically once they come in, is willing to come in again.
Right, yeah. I mean, I think obviously on some level, typically the person will know, particularly in those early stages, they will recognize those changes in behavior and know that something is going on.
And if people refuse because they say there's nothing wrong with me, then one strategy is to say, that's great, come in. If you go to your appointment, then you can have the doctor tell you that there's nothing, that you're fine cognitively, and then we can stop bothering you about it.
Right. But as you mentioned earlier, it is better, obviously, sooner rather than later, because then you have a baseline, right, to start.
Absolutely. We have a baseline, and people are often more willing to come in sooner than later. And that way they can participate in decisions about their care.
Absolutely. So, Carol, thank you. This has been very helpful, very informative. Is there any questions I haven't asked, or anything else that you think we should cover?
I don't think so. You've done a very thorough job with your questions.
Great. Well, thank you again for your time. I really do appreciate it.
My pleasure, and thanks for what you do, helping older people as they get through this,
Yeah,
which is not an easy thing.
absolutely. It takes a village.
Yes, it does.
All right. You take
Bye-bye.
care.
You too.
Bye bye.